We're back on the Short Code Podcast. Hello, YouTube. Okay.
Shall we begin the?
We shall begin the YouTube portion of the show, and that is to that is about our special guest, Frank Canady. Frank Canady, medical student.
What?
Who is taking a break right now. Why are you taking a break, Frank?
Well, the main reason for that is that in early August, I was coming back from a fishing trip with my dad and my brother, and in the back of the car, I had a seizure.
Oh.
And when they investigated that a little bit, they found a brain tumor, which was later revealed to be an astrocytoma.
Okay, so I did a little reading about it, and maybe for those of us who are listeners who don't know a ton about astrocytoma, maybe you can tell us a little bit about what you know about that.
So the type I have was here a grade 3 anaplastic astrocytoma, which means it's a little bit higher grade. Astrocytes are a type of glial cell in the brain, so they're not neurons per se, but they play a supporting role for neurons.
Right.
They kind of feed the neurons, keep them happy.
Yeah, exactly.
Support cells.
I would say that's a pretty good one-sentence description of astrocytes. Like I said, I think you guys kind of.
That's what we want. We want only one sentence. Anyway,
So-
sorry.
Tell us about your life in one sentence. Go.
So you were diagnosed with it. What was the next step here?
So I had it removed. And so Matt Howard, the chief of neurosurgery here, and then Arnold Meneses, who's a neurosurgeon who's been here a long, long time, were the surgeons that removed it. And they removed about 95% of the tumor.
Okay.
At that point, I was in the hospital for about 2 days. They thought I actually might be there a lot longer, so it was a pretty quick turnaround from the craniotomy. And then the pathology report came back that it was a grade 3 anaplastic astrocytoma, which was not what I wanted to hear.
No.
But then I met with my radiation oncologist, John Bawadi, who's the chair of radiation oncology here at Iowa, and then Mohammed Milham, who's an oncologist here at Iowa. And it turned out that my tumor, not me, but the tumor, had a mutation in a gene called isocitrate dehydrogenase 1, which is shortened to IDH1. And that mutation is very favorable.
Oh.
Hey, that's good. So does that mean that there are drugs that can target it?
So what I've read about this so far, and then I got to be careful because I'm on the air here, but what
We can edit.
Yeah, from what I've gathered, it means that the mutation likely made the tumor easier to resect, which is why the surgeons were able to get as much as they could.
Like better borders.
Yeah,
kind of?
yeah,
Nice.
that's actually, I think, a pretty good way to describe it.
Okay.
And from what I understand, may be easier to treat with radiation and the chemotherapy I'm taking.
Okay.
So the radiation I'm doing, radiation appointments tend to last about 15 minutes. That's it.
Wow.
And so I had one this morning, and so we had that at 9. Was out about 9:15. And then let me think. What else? Sorry, one of the side effects of the medication I'm on, I'm taking some anti-seizure medication, is sometimes I sort of lose my train of thought.
That's all right.
You'll have to excuse me.
We do
is that the
we
word
do that too.
finding? The one that causes troubles with word finding?
A little bit. I was taking Keppra, and now I'm kind of switching over to valproic acid, and I can explain why
Okay.
later in the show if you guys want to hear about that. There's a pretty cool mechanism for why I switched over.
I like brains. You should tell us.
Oh, absolutely.
Okay, but continue your story.
So in the chemotherapy I'm on is temozolomide, which is an alkylating agent, and then cetuximab, which is a monoclonal antibody that is normally targeted against EGFR, which is a type of receptor. That has been FDA approved for colorectal cancer, non-small cell lung carcinoma, and head and neck cancer, I believe. I think it's those three mainly. The reason I'm on it is that I don't know if I have this EGFR receptor on my tumor, but they do know that if you give this antibody, it can sort of mount an antibody-mediated immune response against the tumor.
So another front on the battle, I guess.
Exactly.
Yeah. So your body will just help clear it out for you, basically.
That's the goal.
Nice.
How are you feeling? You've been doing radiation for a few weeks now, is that right?
Been doing radiation since not this past Wednesday, but the one before that.
Okay.
So
just almost 2 weeks.
yeah, week and a half.
I'm sorry I missed it. Is it every day? Is it every couple days?
Yeah, that's a great question. I forgot to explain that. That's where I was going with this. So the radiation is 5 days a week.
Okay.
And that's Monday through Friday. The chemotherapy is daily because the temozolomide is a pill.
Okay.
And the total time I take total time I do radiation is not entirely set in stone yet. I have so many appointments, and then kind of midway through they'll sort of do kind of a CT or an MRI or some type of analysis, and I just don't remember which off the top of my head right now. And then they'll add so many more based on sort of the results of that. The chemotherapy I will take daily for the entire time I do radiation. And then that's total time for those is expected to be about 6 or 6.5 weeks. Somewhere in there.
I don't know why, but that seems very, very short to me. But is that okay? Go for it.
But wait, there's more.
Tell me why.
I'll get to that.
Yeah.
So then I have about a month off of all
okay.
that. And then I will kind of get on a cycle where I take the temozolomide 5 days, and then I have 23 days off. And that's, 5 plus 23 is 28, so 5 days every 4 weeks. And I'm on that 4-week cycle, and that's for about the next year.
Okay.
The cetuximab is an infusion every week, 1 infusion per week. So I had my first infusion on this past Wednesday, so 2 days ago. And then I think after, this main bout of chemotherapy and radiation is done, I think the cetuximab infusion is like every 3 weeks. Again, don't quote me on that.
That's all right. I'm not going to quote you.
Yeah, but
No one listens. So, I guess my question is: so you've obviously, I mean, did you know a lot about cancer I mean, obviously, medical students know things about cancer, but you must be learning quite a bit more about cancer than you wanted to know. I mean, do you feel like this is maybe not a great education to have, but useful? So,
in that sense, cancer really is many diseases. So it's hard to say like I know a lot about cancer.
Sure.
Like if Caroline or Casey know a lot about cancer.
Yeah.
I am learning more about brain cancer
Yeah.
than I ever would have expected that I would know.
From both sides of the bed too. I mean,
Yeah.
you're in a really interesting spot where you can both understand kind of the medical side of it, but then you can also understand the patient side of it, which is really interesting.
And that is sort of the interesting thing about it is even though we haven't had brain cancer yet, at least I haven't had it, I think you guys will soon, a little bit more about that. I have enough of a foundation in sort of the medical field or at least I feel like I do from my first year, that I can kind of look up the literature and make sense of most of it and figure out what I don't make sense of.
We've been kind of given a broad, context, foundation to understand more details. Is kind of what you're saying?
Yeah, exactly.
So foundations actually gave us a foundation, you guys. That's the conclusion.
Yeah, it actually did a pretty good job.
Nice.
Pretty good job. And the thing actually is pretty helpful too, especially I'll give a little shout out to CAPS 2 here and Dr. Sibley Rahal. A lot of that stuff with hazard ratios and time to event analysis, so those survival curves, those are pretty useful, and you see that a lot in this kind of literature, just because that's pretty important to look at median survival time.
How does the reading that literature make you feel?
Well, based on the fact that I have this favorable mutation, pretty good, because in some of the literature I've read, people with my mutation, and they did this for 10 years out or so, sometimes the median survival wasn't even reached. So I feel pretty good about it.
It's great.
Yeah, I'm pretty happy.
Yeah. Is this a pretty well-researched type of tumor?
That's a good question. So again, I've read some articles. So the grading and the staging, let's go with the grade, because that's you guys will learn more about this in a couple weeks. But you have like this grade 3, which is an anaplastic astrocytoma. Grade 4 is called a glioblastoma.
Those are bad.
Those
those are really bad.
Those are bad, and they've been studied from the literature I've read and I've gotten from my oncologists and stuff. Those have been studied a little bit more because people want to read more about those, or people want to know more about those. Excuse me. And so that's what some of the literature I've read is about.
Because they're really bad.
yeah, that's a bad type of brain tumor.
And then the grading is based on like what it looks like under a microscope, right?
Right.
Okay.
The interesting thing about that, I did read a paper that discussed the fact that if you look at grade 2 astrocytomas versus grade 3, the real difference there is there's not a big difference in survivability, provided that the mutation in IDH1 is there or not. So it's more favorable to have the mutation, which I have. But there's really not a significant difference in survivability between, or median survival time between grade 2 and grade 3 if you have the mutation. So I think what that's going to show is maybe kind of here in the future we'll be looking at tumors more at a genetic or genomic point of view as opposed to just what the grade shows.
Yeah.
But again, I'm not a pathologist, so
No, I think that's true though. I think that's true though. I mean, it's part of that whole like personalized medicine kind of thing, and you have more effective chemotherapies with less side effects the more targeted you can make something to like a particular mutation or receptor that's very specific to that cancer.
Yeah, and cancer actually becomes very unique in personalized medicine because, in many other forms of personalized medicine, we have some disease process that's going on, but and then you have your genome and how it interacts with that. But in cancer, the cancer has its own genome, and so just like you were saying, there are these mutations that some of them do have and some of them don't have. And I think you got a really brilliant insight there because, it's ultimately far more valuable to know the language the cancer speaks than to just classify cancers by how they look, right? Because like you said, the real predictor is not whether it's a 2 or a 3, but it was whether it had a particular mutation. And I think we're learning a lot more about that now. And I think it's an exciting time to be in that. I mean, given the circumstances.
Yeah.
What are you learning about being a patient?
Well, it's definitely been different than I would have expected at this point in my career. I've learned a lot of this stuff. A lot of this stuff comes really, really fast. Probably the thing I've learned the most is that, I'm pretty, relative to most people that come into a hospital setting, I'm pretty well informed, just given my background as a medical student. Even though I only have 1 year down, I'm still much more informed than most people that come in to any sort of hospital setting. And even then, it's really funny. Those first few days after you get diagnosed, it's a blur. I mean, it is a blur, and I maybe understood half of what the doctors were telling me. It was really good to have my parents there. They live in town here. Yeah,
and your dad is an otolaryngologist, I think you said, right?
Otolaryngologist and a plastic
surgeon. So he's got knowledge. So that's helpful to have on your side too. I think what's interesting, and I've heard this before, what's interesting what you just said is that the first few days are a blur. And I think my impression is that you get so much information thrown at you in those first few days that is almost, I suspect, impossible to process.
Yeah, it was really funny when that happened because it was sort of like being in medical school, just in terms of the information processing. It was just coming that fast.
Yeah.
But it really is a good reminder that when I'm in the clinic or whether I'm a medical student, resident, or an attending physician, with a lot of patients, you've just got to be very careful how you talk to them. Just because they may not be understanding anything you're saying.
be open to repetition, reframing explanations when they don't seem to work, and paying attention to whether they seem to be getting it or not. I mean, those are just sort of basic listening skills, but then also realize that there's that additional pressure of just probably fear and blocking your your ability to comprehend, and then the whole not having the sort of scientific understanding of what's going on for the average patient, I think is probably that much, even makes it even that much harder for them. I would expect.
Exactly.
And they always tell you, don't use jargon, don't use this, but there's more to it than that, right?
Yeah, and the funny thing is, I mean, as any medical student here can attest to, I mean, it gets very easy when you're around medical school all the time and you're around other medical students all the time, just to start using that jargon. Even when in simulated patient cases, I mean, that is very, very easy to sort of slip into that.
You forget what even counts as jargon, because like something, some of the cell pieces that maybe you technically learned in freshman year of biology in college, and you're like, oh, like everybody knows what a cytoplasm is. No, most people do not know what a cytoplasm is. Even most people who went to college don't know what a cytoplasm is because they didn't take biology or they didn't like biology or it's been so long, and it is, you're right, it's really easy to assume that words that have become basic and fundamental to you are not basic and fundamental to most people's lives.
So, as you proceed through this journey, are you purposefully thinking of things that you can take away from this, or are you just going with the flow? I mean,
a little bit of both.
Yeah.
So I think the one thing that will be very interesting when I get into the clinic is that, in a sense, I will have been sicker than a lot of patients that I see, because I mean, it's brain cancer. I mean, how much?
Yeah, there's.
That's not a great thing to hear.
How much worse does it get?
Congratulations on reaching the pinnacle of sickness.
No, but I mean, I feel fine, and but it'll give me right now. But this will certainly give me, I hope, a little bit more insight, or at least a different view than most medical students have. Because I mean, fortunately, most medical students just don't deal with this type of illness at least when they're in school.
Right. I can think of a couple of cases, but not many in my past 13 years. So I guess that's fortunate. But
what are you doing in your year off? Not just doing chemo and radiation, I assume.
No, I'm hoping to just kind of continue with some of the work I did this summer. So working for Marlon Hansen up on the 5th floor here in CBRB. He's an otolaryngologist, and so I'm going to be doing some work on cochlear implants and some stuff with vestibular schwannomas as well.
Nice.
So, I'm still trying to kind of get this treatment stuff worked out. So I've sort of been in and out of lab as I've been scheduling and setting up appointments. That's the other thing I've learned too. Is just that there's a lot of work that just goes into just scheduling and setting things up and just trying to make sure you need to be here at a certain time. I mean, it's a lot of work.
You need a secretary.
Yeah. Almost.
Well, I think it's
you can hire a pre-med intern.
Yes.
I think that's a really good point, though. I mean, when you see really sick patients and they have 8 different doctors and they've got to go to these different ones, and if they keep missing appointments, then the person who's sort of in charge at the head of all of it, in your case, would be sort of the oncologist. But in other cases, it's the primary care provider. What are they going to do, right? And I think it's actually a good point. How do we get people who need it? What amounts to being an advocate or a secretary in that sense, to help them figure out how to get there.
Yeah, and I think you're very lucky too that you live in town and your family's right here. Like, that's really nice. Because have you been staying with them, or?
Yeah, I have.
Okay.
And I lived over at Firo. I'm still paying rent and stuff there. But for now, we're just a little bit worried about some of the effects of the chemotherapy. So primarily just potential for a weakened immune system. So far, last blood count I was normal. So, no issue there. But we're just kind of trying to make sure that stays normal before I can go back there.
Sure.
Yeah.
But yeah, so like, your parents can give you rides and stuff too if you need that because you can't drive.
Yep, because I had a seizure, I can't drive for 6 months after the seizure.
So yeah, and I mean, like, that's also another kind of thing that doctors kind of forget about. Like, if somebody lives out in the country or in another town and has to come in, like, there's a lot of really complicating factors that can make an already just naturally complicated process like a million times worse.
The other thing I'd add in there too that I never thought about until this happened. So, there's really a lot of can'ts that are involved in if you have a seizure or if you're epileptic that I never thought about kind of until this happened. But I mean, so you can't drive, you really can't swim, or at least you can't swim unsupervised because you could seize and drown. You can't be in high places or on a ladder because you could seize and fall off. You can't you can't use like power tools. Because you can seize and hurt yourself doing that. I mean, there's just a lot. I mean,
there's a lot of things that you do in your everyday life that actually put you in danger.
Yeah.
When you are, not at risk of seizing, and then you throw that in, and it's like, wow. I never really thought about that because I knew you couldn't drive. I mean, that's pretty clear, but I never thought about all the other things. That's interesting.
Yeah, and it's kind of funny because I mean, you think about how that would affect somebody that, like, what if you can't use power tools? I mean, what if you were in a job where
a carpenter or a plumber or any number of things.
Yeah, right. I didn't even think about that until Mark Granner, my neurologist, went on this list of stuff that it's like you can't do this for a while because of this.
Was there something that surprised you the most about things that you can't do?
Really kind of. So the driving thing, I knew.
Yeah.
I knew that, but surprise. Really the ladders, the swimming, and the power tools. I mean, because it made sense in retrospect, but it's certainly not something I would
never have thought of swimming, for instance.
Thought of this, right?
Yeah.
Bikes?
As far as I know, I can bike.
That's good.
After that's the thing. So I normally am pretty active. So I like to run, and I like to bike as well. But I can't do that until 6 weeks after my surgery. So
sure, at least because up here is
healing
and
because of my skull.
Yeah.
And so I can't run or bike until I guess it would be 2 weeks from yesterday. But as far as I know, I think I can ride my bike. I was actually kind of hoping to do that so I could.
You can do Ride for Youth.
Well, is that in the fall now?
No, it's not until April or something.
Oh, he'll be.
You got plenty of time.
Yeah. Hopefully by that point, I don't know. I should be able to, but I'm kind of hoping to start biking as soon as I can. Just one, because it's fall. I like biking outdoors and stuff, and two, just kind of as a mode of transportation.
Frank, you don't know about this, but at least probably Casey and John do. I was ill a long time ago. This is a recap for our listeners too, because I've said it a few times. I was ill a long time ago. ICU. I had Guillain-Barré syndrome. Anyway, the point is that the one thing that I kept hearing from people is you should write a book about this, and I'm like, and I guess a well-intentioned suggestion to do that. But has anybody said that to you yet?
Several people. I'm actually been chronicling some of this.
Oh, fantastic!
So yeah,
fantastic.
That does remind me, though. I think this segues really nicely into a question I wanted to ask. Like, how do you feel this has changed your identity?
As of right, wow, that's
a really deep question.
Yeah, that's a really good question. I think the answer for that will sort of come in time. I'm not sure I can give you something quite yet for that. I wish I could give you a better answer than that right now. But I can't right now.
It's
I'm sorry.
It's such a big question, and and life is that moving target. But I think the reason I ask that is because you're already hinting at things that I think really that really shock us when we go through them, like, oh, now I can't do blank anymore. Now I have to sort of define myself, as it were, as a person who can't swim or whatever, right? And again, these are temporary restrictions, but that's the reason I asked that, and not to put you on the spot, because it's such a huge question.
Oh, no, it is, absolutely. The other thing that really changed my perspective, though, I guess maybe to give you part of an answer for that, is just how quickly you can go from being in perfect health to almost one of the worst things that can happen to you. Because cancer is, not that I have the worst kind of cancer out there. I certainly do not.
Right.
But it's still cancer, and it's still, as people have told me, it's still malignant.
It's still the doom word. It's the word that nobody wants to hear.
Exactly. And so it's pretty amazing. That was probably from the seizure to finding out, that was 2 days.
Yeah.
And so basically I went from...
Like during a test week, right? Or no, I guess your first seizure was during a test week.
Yeah, that was back in May. So that's the thing I didn't add in here. I'll give the listeners some information. So I had a history of these, but I also have I ran competitively for years, and so I've always kind of had a low heart rate, and so some of this was masked by that, and they thought I was a vasovagal response. But this one in August, my dad saw, and it was definitely a grand mal seizure. And so that was on a Wednesday, and then I found out I had this tumor on a Friday. And so it really is amazing how you can go from perfect health to cancer in just 2 days.
Yeah. It takes, that's something that I remember too. Is like, at least in my case, I went down really quickly, and it is shocking. It is. I don't know that there's any worse shock. There are many types of shock, but this is among the sort of craziest things that can happen. Is to have your health go south that quickly.
Yeah. And especially when you really, it's not like from that Wednesday to Friday I felt any different. I didn't feel any different at all.
Well, that's a crucial difference between my situation and yours. Yeah. So, yeah.
No, I felt fine.
So part of you is like, oh, okay. I'm good.
What do you mean I have a horrible disease? I feel fine.
What's the problem? All right.
Now, if I could, I have a question about
your... Please do.
Goodbye.
Oh.
No. You and your family's response to this, I feel like some families, and maybe myself included, I don't know, haven't been in the situation, would have kind of like folded in and kind of kept to myself. But your family is very different. You got on Facebook and you sent, a message to everyone. Your family had an open house, invited our whole class to your house. Can you tell me a little bit about that decision that you guys made, and how you think it helped you?
Oh, just that I kind of, the day I found out I had the tumor, is just kind of like, I know I'm not going back to school, because I thought I'd be in the hospital for about 2 weeks. And so it's like, I'm just not going to make it back to school this year. And so the first thing I did was kind of wanted to let everyone know, mostly just why I wasn't going to be in your class this next fall.
Yeah, if you disappear for a year and then pop back up a year later in the class below us, like, what happened?
Yeah, and so the amount of support I received from the class was amazing. The amount of support I've received in general has been amazing, but just especially from the class of 2018 has just been astounding. And so we thought that, if we had kind of an open house, people would come and just kind of get to see me once before I had surgery, and it went well. It was good. But, my parents, just like you could probably imagine you would if you were a parent, they took the diagnosis pretty hard. So, but they've put on, they've been strong.
You think it's been better or worse for your family being in medicine? Like, has it been harder for them or easier for them? Or do you even feel like you can answer that question?
Oh, I would say almost certainly easier.
Yeah.
Because my dad, he worked with like Dr. Meneses and Dr. Howard for years. And so just getting me access to that care as quickly as he was able to.
Even just navigating healthcare, I imagine, as a general topic, has to be a tremendous benefit.
Yeah, but no question that, I doubt that I would have been able to, have the surgery as soon as I did, because I had the surgery the next Thursday after I found out. So 6 days after I found out I was diagnosed, I had the surgery, which is a pretty quick turnaround.
Well, we have to sort of wind this up, but I want to say that I'm glad you're with us. I'm glad things are going pretty well for you, and it's nice to see that your surgery was uncomplicated, and I guess, and good job.
Now here's the real question: How are you on your supply of
headgear?
Head wraps.
I told him he looks like a surgeon because it's totally like a surgeon's cap.
Perfect.
Did you are people making these for you, or how do you get such a variety?
I bought 3 of them, and then 3 more were made for me. So
open
cool.
call. Anyone in the business of making small do-rags?
Make do-rags.
Not large do-rags. We don't want yours. Small do-rags.
Oh,
only,
boy.
Please.
Surgical do-rags.
Yes.
Surgical do-rags, please.
We'll
Keep
be back.
it professional.
We'll be back in just a second on the Sherco Podcast.